like ships in the night. You keep passing me by.
Hey everyone, Cameron Eldred here, doctorate and athletic training student through Indiana State University. Today we're going to be going over the myofascial reading assignment that was given to us this week. We reviewed 5 different articles that have to do with myofascial release, and we were asked to synthesize them, talk about them. As you can see, I used a mind mapping method here. Kind of the articles were the central idea of everything, and then everything kind of broke down from there as to what articles we were looking at. So the first thing that we're going to go ahead and do is we're going to look at these different articles. Apologize there, I went the wrong way. So the first 2 articles that we're going to look at is Introduction to Soft Tissue Release and Soft Tissue Release Techniques. I put these together because it just made sense to me. They were both hand in hand. They talked about the where, when, whys, what exactly it is. So we're going to cover all those things right now. So Introduction to Soft Tissue Release, what is it? So it is an advanced massage technique that's helpful in the assessment and stretching of soft tissues. These are things that we do every single day as athletic trainers. We assess injury, we assess soft tissue, we do all those different things, and we also stretch our patients. We try to assist them in becoming more pliable and flexible and things like that if that's what their treatment warrants. This also allows for targeting release of a specific area within a muscle. This is great for stretching areas that are really hard to get to. So if the target area is really difficult, we can use a locking position. We do this by creating a false insertion point to provide a more intense stretch, of course, to a specific area. So looking at this little picture, these pictures here, you can see that when we primarily start, we usually just stretch a patient out. We're getting a good calf stretch on them and stuff like that. But say we want to limit the area of stretch that, they're having issues with. And so what we do is we create that lock or that false insertion point by placing pressure, and then we put them through the stretch. At that point, we would release, move our hands a little bit further down. As you can see, we move a little bit further down the muscle belly. Area of stretch gets a little bit smaller, but it becomes more intense. And again, we place pressure. Next up, again, a little bit farther down, very little stretch is occurring up in this area of the calf. But down here, we're having a lot more of an intense stretch. So again, we're creating those insertion points. Remember that the patient should stay relaxed. The patient shouldn't be tensing up, but they do need to provide feedback, because if it's painful or if you're not stretching the right area, it's extremely important that you release and reposition so that you're able to correctly provide the proper treatment for your patients. I apologize ahead of time for not saying this. My child is still awake, and it's extremely late. So if you do hear him screaming, I apologize. This is the only time I can find to do this. So where, when, and why? So we use this to stimulate tissue repair. Of course, we're lengthening and encouraging the pliability that's within those tight tissues, and we're trying to orientate the collagen fibers during this healing process that may be going on. Now, who should have the hot soft tissue release? We're looking at anyone who takes part in exercise, recovering from some type of musculoskeletal injury, anyone who maintains static posture for long periods of time, treatment for any kind of lateral epicondylitis, medial plantar fasciitis, things like that. Anyone who needs treatment for increased muscle tension, maybe even old scar tissue. Basically, anyone who needs treatment of trigger points, of course. So that's kind of, who should receive this? So of course, where can we do this? Like, where can this be done? And it was kind of funny when reading the article, because it says it can be used anywhere because it may be performed through clothing or a towel or in prone, supine, or seated positions. So it gives you a whole lot of different options. I mean, it says in the office, while seated, in the park, on a tennis court, on a golf course, by a pool, in a clinic, at home. This is kind of like the jack of all trades. You're able to do this wherever you would like to, because it's easy. And once you understand the concepts behind it, then, it's easy to apply, especially when you're trying to apply this type of thing to yourself. This is one that you can teach a patient how to do, and they can do at home. So When should this be done? This should be done pretty much at any time as long as there's a purpose for it. And you can do this anywhere from once a week to, a few times a week, and you're going to be getting benefits from it. So why would we be doing this? What's the purpose of, like, what are the benefits? It's used for a multitude of reasons. Perhaps most commonly, it's just to stretch out soft tissues. It's beneficial because it improves flexibility, posture, alleviates pain, especially pain that's not focused on joints. So muscular pain, soft tissue pain, haha, soft tissue. Um, and it helps therapists assess the degree of tension and that's within and between those soft tissues. Um, so, you know, how can we incorporate this into our everyday practice? And this can this can become tedious, I guess you could say, if you're working in specific settings. If you have the time to do this with all your patients, that's great. I personally don't have the time to do this with every single patient that I see. So this is where patient education becomes very important. But what we're going to do is we're going to go through the 3 different types of soft tissue release. We have passive, active, assistive, and active soft tissue release. So the first 2 they're actually pretty similar when you're looking at them and how to perform them. So with passive soft tissue release, you need to identify the muscle needs to be stretched, but remember that you need to focus on the direction of those muscle fibers. Ensure that the muscle is in neutral position. Neutral means that the muscle is neither shortened nor it's stretched. So it's just sitting there. And this might be, if they're really tight, it might not look normal, but for them, it's neutral. So just have them relax. Make sure that you are explaining the procedure to the client. This is something that, when we first start as clinicians, we tend to forget how to do. So we need to make sure that we're explaining what's exactly going on so that they can give us feedback. Lock the muscle in place in a neutral position first. So neutral position, lock the muscle gently to fix those fibers. While you have your lock, stretch the muscle. Once it's been stretched, release the lock, return the muscle to neutral, and then choose another point to fix that muscle. Remember to work proximal to distal. Again, when you're doing active assistive, everything's practically the same until you get down to the stretching portion, because at this point you would have them do a movement on their own. So while maintaining the lock, you ask them to move in a way that they feel it stretch in the muscle. So that's where we're looking at the active assistive. And then again, once the muscle's been stretched, release the lock, choose another fixed position, working proximal to distal. Next, we're going to be looking at active soft tissue release. This is going to be a little bit more different. So you're going to identify the muscle, shorten the muscle. So it means that you're concentrically contracting that muscle. So again, this depends on the muscle that you're working with, but as professionals, we should understand what that means. With some of the muscle shortened, lock those fibers, of course, starting proximally, nearest the origin of the muscle. And then once the fibers are locked down, then you lengthen that muscle. Maintain the lock throughout the movement, of course, and then remove the lock, allow the muscle to shorten, and then choose a new place to start. Again, working proximal to distally. So again, that comes back down to the incorporation of, how can we do this within, our clinic? You can use this before, during rehabilitation or exercise. You can combine it with other manual therapy techniques, as well as use topical products and other such things like that. I apologize, I lost my train of thought there. So next we're going to be looking at the comparison of short-term outcomes between trigger point dry needle and trigger point manual therapy for the management of chronic mechanical neck pain. Now, I don't know about you guys, but this is something that I have definitely experienced in my life. So this article was super awesome. So the criteria that they looked at for the study was, of course, neck and shoulder pain. Pain was self-reported to a physician, and then the physician referred them out. They also looked at range of motion for being a criteria within. The outcomes that they were hoping to look at was significant and important improvements with an inability to determine primary change to either treatment due to no control group. So there were significant and important improvements, within the patients. However, again, they were unable to determine the primary change. So whether it was trigger point dry needling or trigger point manual therapy. So they weren't sure which one exactly it was because they received it because there was no control group. So they didn't know which one made them better. So what was the point of this? Neck pain is commonly associated with muscle trigger points. So if you think about it, a lot of us, especially in our upper trapezius, may have those trigger points, especially depending on our posture and things like that. A lot of this pain is present in patients who report what's called insidious mechanical neck pain. So that's why we're looking at this. Now, the interventions that were used, I apologize. Got ahead of myself there. So some of the previous theories that they were looking at with this as well was that manual therapy targeted cervical joints as well as deep neck flexor exercises. These things have been widely accepted as the go-to for this pathology, for neck pain, loss of range of motion, and things like that, especially as it moves down into the shoulders. For physical therapy management of patients with this pathology, they've included manual therapy, cervical spine manipulation, mobilizations, training, massaging of deep neck flexors, things like that. Soft tissue interventions may also provide immediate improvements in patients with the pathology. So basically what they covered at the beginning of this article was that, combining all these different therapeutic interventions, we can improve patient outcomes. So looking at the interventions that were used within this, we're looking at trigger point dry needling, which, as you can see, is not my favorite thing because I'm afraid of needles. But basically what they did is they inserted a needle into the upper trapezius. It was inserted about 10 to 15 millimeters into the trigger point that was located. Once they received a first twitch response, the needle is moved up and down, almost like a piston within an engine. They got 2 treatments over a period of 2 weeks. Next, they looked at trigger point manual therapy. So they used pressure point release over the trapezius. Pressure was maintained until relief was felt by the clinician, so the clinician could actually feel that trigger point release and relax. This was repeated 3 different times. Now, stretching with both of the thumbs and the clinician placed above and below the trigger point, as you can see in this picture, whereas the first portion was just pinching between the index and the thumb. Sliding fingers in opposing directions, so you're pulling the skin apart. Passive stretching for the upper trapezius was performed for 45 seconds. Again, 2 treatments for 2 weeks. Again, the outcomes that they had with this was basically that working together, they were able to find that, of course, there was a great amount of difference in what the patients were feeling. Both groups, again, reported that significant and clinically important improvement. No control group was used. So again, we were not able to attribute the change in the patients to either treatment or passage of time. Slightly higher improvements, however, were seen with the dry needling group. So the next article that we're going to talk about, this is where things kind of got a little interesting for me, and I actually learned the most. But again, it's kind of hard for me to place these things into words. And I don't know why. It's just kind of how it is for me. So we looked at the etiology of myofascial trigger points. So we're looking at sensory motor autonomic symptoms, local and referred pain. But why are these things such a pain? That's the question. So sensory motor autonomic symptoms are usually caused by myofascial trigger points. They're severely tender spots within a tight muscle belly. Local and referred pain, again, are, a big part of this. So why is a trigger point so painful? So why are they such a pain? So they prevent full lengthening of a muscle, which weakens the muscle, mediates a local twitch response of the muscle fibers when adequately stimulated. That comes straight from the article. So basically what we're looking at here is, you don't get a full length of that muscle. The muscle gets weak. This creates a twitch response of those muscle fibers when it is stimulated. And so you end up with those tight, horrible, twitches or pains that we've talked about. So some of the theories behind this, or that were mentioned, so muscle damage creates a disruption within the cell membrane, which allows for a release of calcium ions. So once that happens, we end up with an impaired oxidative metabolism. So during this, the sustained muscular contractions, the metabolism is highly dependent on both oxygen as well as glucose. And if these things are not abundant, and we're looking more at calcium, we start looking at that impaired oxidative metabolism, so the body's not able to get it through. Sarcomere contraction occurs, which is when the ischemia as well as hypoxia occurs. So that lack of oxygen. This leads to a release of several substances that cause a peripheral sensitization. The body then runs out of ATP, causing the sustained contractions because it can't move. It's stuck, which causes that trigger point, that painful muscle belly. So that was the etiology of it. So, the best available evidence through that showed that trigger points often develop after muscle overuse, with eccentric overloads, submaximal sustained contractions, submaximal concentric contractions. So a big key factor within the etiology of this was that local ischemia. This led to a lower pH and a release of several different inflammatory mediators into the muscle tissue, which causes just that giant, I guess I would liken it unto a car wreck, which does not allow for ATP and other things to do what they need to. And so you end up with that trigger point. So the next and last article that we are looking at was myofascial trigger points, translating molecular theory into manual therapy. Again, theories here. I'm terrible at trying to explain these things. I get it, but it's hard for me to get the words out. So myofascial trigger points are an extremely common cause of non-articular pain, which I've mentioned before. So it's mostly contained within the muscle and the muscle belly. The motor end plate, which is kind of like, so Simmons was one of the contributors to this, implicated that the motor end plate is the central etiology of myofascial trigger points. So the end plate itself is responsible for transducing or bringing in that electrical potential into a muscle contraction. So it's the one that's responsible for creating this. Motor end plates that are dysfunctional but still produce muscular contractions kind of lead the way for this energy crisis, this ATP energy crisis. This causes both sensory as well as autonomic reflex arcs, as well as central desensitization. So, you end up again with these myofascial trigger points that just do not feel good at all. So the way that I kind of like to look at this, I thought this was kind of a funny way of looking at it. But basically, you cause, damage to the muscle. But the question is, what caused that damage to the muscle? Because obviously, he has this snake, and he's using the wrong thing to be able to create water. So what is the root of the problem? Well, he's using a snake. So in this case, it would be damage to the muscle. So what's wrong with the muscle, and why is it having issues? The chemicals begin rushing to this area for muscular fire, so that the muscle can move. So in this picture, the guy's going to turn on water, but nothing's going to come out. And we've got to figure out why. And if we continue to just treat the fact that there's no water coming out of this, so let's just keep, moving the snake around rather than getting down to the root of the problem, which is the fact that his tail is stuck inside of the spout. We're just going to keep treating these symptoms over and over and over. So what we need to do is we need to treat the root of the problem, not just the consequences. So we're trying to treat, the beginning of this. So another way of looking at it is you've got a leak somewhere within your house. What's causing this leak? Is it a main pipe that's leaking? You're flooded. Is it a main pipe, or are we just going to treat, we're just going to pull out the carpet and put new carpet down. And then once that carpet's soaked through, we'll do it again. So it comes down to, how are we treating these patients? How are we treating this injury? So overall, I hope you guys were able to learn something from this. I apologize. It was really long-winded. I just learned a lot from these, and there was a lot to say. So these are the articles that we went through. If you have any questions, please feel free to reach out and let me know what you thought. Guys, have a wonderful day. Thanks.